Okay, welcome everybody to today's session, Managing Side Effects of Targeted Therapy. My name is Don DeFelice. I'm the husband of Carol DeFelice, who was diagnosed with thyroid cancer back in 2008. And ever since then, she's been involved with ThyCa very actively, and I've been helping out for many years also. So we'd like to welcome you to this session. For today's session, we have Sarah Hamidi, who is an MD, and she is board certified endocrinologist who just completed a 2-year fellowship of endocrinologic oncological endocrinology at University of Texas MD Anderson Cancer Center in Houston, Texas. Her clinical practice and research interests focus on the management of advanced thyroid cancers, particularly anaplastic thyroid cancer. She participates in several research projects aiming to improve the management and outcomes of this rare yet very aggressive disease.
Thank you so much for the introduction, and it's my pleasure to be with you guys here this afternoon to talk about the management of side effects from systemic therapies that we use for the treatment of advanced thyroid cancer. Okay, awesome. So as most of you probably know, what we use for the treatment of advanced thyroid cancers is what we call targeted therapies. And why we call these treatments targeted therapies is because they target specifically the cancer cells as opposed to traditional chemotherapy, which interferes with all rapidly dividing cells. And so the goal of using targeted therapies is that these drugs are going to be less harmful to normal cells and so come with less side effects than the conventional chemotherapies, but they're also going to be more effective against the cancer cells. And the targeted therapies we use in advanced thyroid cancer fall below the family of kinase inhibitors. So thyroid cancer, what are these kinase inhibitors targeting? Well, actually, thyroid cancer is caused by a genetic abnormality that is going to happen within the thyroid, and that is going to lead to uncontrolled cell proliferation, survival, and eventually lead to the formation of a tumor. And these genetic abnormalities are called oncogenic drivers. That's what drives the tumor to happen. And there's two big families. They can either be mutations or fusions. Mutations are when a gene is damaged or changed, resulting in an error in the genetic message that is sent. And so this genetic message is going to be abnormal cell growth leading to cancer. And a fusion is when two genes that are not supposed to be next to one another become next to one another. And this again leads to an abnormal message that is sent, and that leads to uncontrolled cell growth. Okay, so what the most common mutations that we find in thyroid cancer are either in the BRAF V600E, in RAS, or in RET. And then the most common fusions that we're going to see are in RET, NTRK, BRAF, and ALK, but fusions altogether are relatively rare in thyroid cancer. And all of these oncogenic drivers are what we call mutually exclusive, meaning if you have one, then you won't have the others. We have several drugs that specifically target these genetic alterations. So we have BRAF MEK inhibitors, which are TAF and LAR mechanists. We have RET inhibitors, which are selpercatinib or Retevmo, and pralsetinib or Gavreto. And we also have NTRK inhibitors, which are larotrectinib or Victravi, and entrectinib or Rozlytrek. But some patients, unfortunately, don't have a specific mutation that we can target. And when that happens, what we use is what we call a multi-kinase inhibitor. So multi-kinase inhibitors are going to target the tumor's blood supply. They're still specific to the tumor, but they're not specifically targeting a genetic alteration. And why do we target the tumor's blood supply? It's because the tumor depends on oxygen and nutrients that are brought to it by the blood to survive. So as the tumor grows, it begins to need more oxygen. And so it's going to make this protein called VEGF to increase its blood supply and oxygen delivery. The VEGF is going to go to its receptor, and this leads to an increase in the blood vessel, allowing more oxygen, more nutrients to come to the tumor, and so the tumor is able to survive and grow. What the multi-kinase inhibitors are going to do, they're going to block the VEGF receptor. So VEGF can no longer go to its receptor, and the tumor is not able to increase its blood supply, and that's eventually going to lead to tumor death. There are several multi-kinase inhibitors that we use in thyroid cancer. There's cabozantinib, which is used in both differentiated and medullary thyroid cancer. There's lenvatinib, used both in differentiated and anaplastic thyroid cancer. And then we have sorafenib, which is an older drug that we used to use for DTC, but we use less and less nowadays. And then finally, vandetanib, which is used in medullary thyroid cancer. Now, I said that these drugs target the tumor specifically, and so they come with less side effects than conventional chemos, but they still come with some side effects. Looking at the BRAF/MEK inhibitors, so TAF and LAR mechanists, the main side effects that we deal with are fevers and chills and skin disorders. And then there's some abnormalities that we see in the labs, like low phosphorus, elevation in the liver enzymes, anemia, and high blood sugar. For the RET inhibitors, so pralsetinib and selpercatinib, the main side effects clinically that patients are going to experience are dry mouth and hypertension. We also see some swelling with selpercatinib. And then again, we have some abnormalities in the labs, mainly elevation in the liver enzymes, and also decrease in the blood counts for pralsetinib. And then finally, the NTRK inhibitors, which are much more rarely used in thyroid cancer, but their main side effects clinically are dizziness and some fatigue. And then again, we have decrease in blood counts and elevation in liver enzymes that can happen. Because of these side effects, unfortunately, some patients need to have their doses reduced, their treatment interrupted, and sometimes even need to stop treatment. In the clinical trials that studied these drugs in thyroid cancer, about 1/3 to 1/2 of patients needed their treatment, their dose, reduced because of side effects. But fortunately, a very small number of patients needed their treatment completely stopped. The highest percentage was with dabrafenib trametinib, about 20% of patients, but for the RET inhibitors, they're usually relatively well tolerated, and very little patients need to completely stop treatments because of side effects. For the multi-kinase inhibitors, because we're targeting blood supply, side effects are much more common and much more numerous. And you can see that this table is very heavy because unfortunately these drugs come with multiple side effects. And we're going to go through them more in detail throughout the presentation, but the main ones that we deal with are high blood pressure, fatigue, decreased weight and appetite. Diarrhea is a main one as well. And then we can have various skin toxicities, the most important one being the hand-foot syndrome. And we're also going to talk about that more in detail. And then each one of these drugs comes with its more severe but less common side effects. For lenvatinib, there can be high protein in the urine. For cabozantinib, there's a 25% risk of bleeding. And then for vandetanib, the most serious but fortunately relatively rare side effect is QT prolongation, so an abnormality in the EKG that can lead to heart arrhythmias. And you might notice that the percentages, the frequency of side effects is less with vandetanib compared to the other 3 drugs, and that's because it's a weaker anti-angiogenic, so it blocks less potently the blood supply, and so that's why it's better tolerated than the others. And because the multi-kinase inhibitors come with much more side effects, much more patients need either their dose reduced, their treatment interrupted, or even their treatment completely stopped because of side effects. So up to 80% of patients need their dose reduced or their treatment stopped. And then about 15 to 20% of patients on a multi-kinase inhibitor will have to completely stop treatment because of side effects. And so why do we care about these side effects? Well, it's because ultimately they're going to negatively affect patient outcomes. As I mentioned, we saw there are many of these side effects that are relatively common, and if the patient is experiencing one or several of them, this can lead to a decrease in their quality of life. Sometimes they need to hold their drug or have dose adjustments, and sometimes they even have to stop treatment because of side effects, and that's not something that we want. We want to have a treatment that effectively works against the cancer. If the patient has to miss school, miss work because of side effects, this leads to financial toxicity. And then if the patient is really having several side effects that are not well controlled, they can just pursue their whole disease and medical team negatively. And some patients might not even want treatment anymore because they're having so many side effects. And so ultimately, if the side effects are not well managed, this leads to poor patient outcomes. And this really is against what we want. And so that's why it's important to know about these side effects and to manage them appropriately. Other than factors associated to the drug itself, there's also factors coming from the patient and the tumor that affect the side effects that a patient is going to go through. So one very important point is patient comorbidities. If a patient already has hypertension that is not well controlled, then we know if we put them on a multi-kinase inhibitor, we might have more trouble managing their blood pressure. And all of these patient comorbidities or pre-existing medical issues need to be well managed before going on a multi-kinase inhibitor. And it's very important for your doctor to be aware of what medical issues you have when they're starting you on a systemic therapy. It's also important to know what the performance status is, meaning how well is the patient, how active they are, because if we're already dealing with a very frail, very weak patient, then we might need to either pick a less toxic drug or a lower dose of a drug so that they don't get worse and are not able to tolerate their treatment. And then we also need to know what their baseline symptoms are, because again, depending on what they're already experiencing, we might want to pick a drug over the other. And then there's also tumor factors that are going to affect our decision. Depending on where the tumor is, sometimes there are a higher risk of complications with certain drugs compared to others. So it's also important to take this into consideration. And so when we're picking our drug, we're going to consider all of these factors. And these factors are also going to affect the dose that we choose. So now let's talk about the most common side effects and how we manage them. But before going through each side effect in detail, I just wanted to let you guys know how we grade side effects in clinic. So when we have a patient reporting a side effect, we're going to determine how severe it is, and that's kind of going to help us know what we're going to do with the side effect. And so this is a standardized way of grading side effects that all doctors prescribing systemic therapies are going to use, and it also allows us to all speak the same language when we're taking over another patient's care, for example. So a grade 1 adverse effect from systemic therapy is a mild one, and usually there's no intervention that is needed. Grade 2 is moderate, and usually just either no intervention or just supportive measures are enough. If we have a grade 3 side effect, oftentimes we need to hold the drug while we're managing it. And then grade 4 is a life-threatening side effect, and grade 5 is a side effect that leads to death. And this is kind of a general way of how we manage side effects based on their grade. So as I mentioned, grade 1, usually it's supportive measures only. Grade 2 with tolerable symptoms as well, we're just going to do supportive measures. But if a patient has a grade 2 side effect that is intolerable, that is difficult to control, then sometimes we need to hold drug while we're helping them manage the side effect. And once it's under control, that's when we're going to go back on the treatment. For grade 3 side effects, which are more significant, we usually always hold drug until the side effect has resolved or is under control. And we sometimes need to resume the drug at a lower dose. And then if there's a grade 4 side effect, then we're going to stop the treatment completely. So now let's talk about the most common side effects that we see. And one of the main ones that we have to manage on a daily basis, especially with the multi-kinase inhibitors, is hypertension. So it's a common one with multi-kinase inhibitors, but also with the RET inhibitors. And it's very important to manage this hypertension aggressively because if it can go very quickly. If we don't manage it well, it can go out of control and lead to severe complications like heart failure or neurological complications, and we don't want that. So it's very important before starting the treatment to make sure that the blood pressure is well controlled. And then once the patient starts the treatment, if we know that this drug can affect the blood pressure, it's important for the patient to monitor their blood pressure very closely and send to their team these numbers so that we know if we need to intervene on them or not. And usually if the blood pressure is consistently over 140/90, that's when we're going to want to start treatment. There isn't a drug that is better compared to others when we're talking about management of hypertension caused by a chemotherapy drug. So really we can use any of the drugs usually. And this is just to give you an idea how we grade the hypertension. So again, it's when it's over 140/90 that we're going to want to start treatment. And if the blood pressure is over 160/100, this becomes a grade 3 adverse event. And so when this happens, we need to hold the drug while we're managing the hypertension. And it's only when the blood pressure is well controlled that we can resume the treatment. And sometimes we need to resume it at a lower dose. And then grade 4 hypertension, it's when it's causing severe complications, like I mentioned, can lead to heart failure, to neurological consequences. And if that happens, then we need to stop the treatment altogether. The next side effect I wanted to touch on is diarrhea, because that's also another frequent one that we see with a lot of the drugs that we prescribe for advanced thyroid cancer. The way diarrhea is graded is by number of stools per day. And so, a grade 2 is 4 to 6, grade 3 is 7 or more. So when a patient starts having diarrhea on a kinase inhibitor, if they had normal bowel movements before the treatment, then of course the first thing we want to exclude is another cause for diarrhea. We can't just assume it's coming from the chemo. We want to make sure that we're not missing anything else. So make sure there is no infection or any other cause for diarrhea. And once we've ruled out all of these conditions and we know that it's coming from the chemo, then one thing that can help is to keep a food diary, to try and see what makes your diarrhea worse, what makes it better, and try to avoid the foods that make it worse. In general, foods that can make the diarrhea worse are spicy foods, fried or fatty foods, dairy, and caffeine. So it's good to stay away or minimize these foods as much as possible. And then if you're having a lot of bowel movements, the risk with that is dehydration. So it's important to stay well hydrated to prevent the dehydration. If these supportive measures are not enough to control the diarrhea, then we have some medicines that can help, like Imodium, Lomotil. There's also Metamucil, and there's a recipe there that you can use to help with your diarrhea. And then if these first-line treatments don't work, we also have other tricks up our sleeves, like tincture of opium, that can help severe refractory diarrhea. And sometimes if the diarrhea is not responding to any of those treatments, then sometimes we even have to hold the drug or go down on the dose if it's causing severe diarrhea. And just of note, these things can be combined together. It doesn't need to be one or the other. So combining drugs sometimes can help better control the diarrhea. The next one I wanted to touch upon was nausea, which again can happen with a lot of the drugs that we prescribe. And basically the way nausea is graded is if it causes no changes in the way you're eating, it's mild. And as soon as it starts decreasing the food intake and even leading to weight loss, that's when it's considered more severe. Similar to the diarrhea, one way that can help you manage it without medication is to keep a diary, looking at what makes your nausea worse, what makes it better, and try to avoid the foods that make it worse, especially spicy food and fatty foods. Also, foods with strong odors can make the nausea worse or even cause it. So avoid foods that have strong smells or smells that you don't appreciate. If you have a lot of nausea, sometimes it's hard to stay well hydrated. So you have to be mindful and make sure that you're hydrating well. And then one thing that can also help if you're having nausea is taking smaller meals more frequently during the day. And then again, if these supportive measures don't work, we also have medicines that we can use, like Zofran, Compazine, Reglan. And again, these drugs can be combined together. So if you're doing all of this and it's not working, then make sure you're asking your doctor, can you prescribe something for me because I'm having significant nausea with my chemo. The next side effect is one that I find particularly challenging to manage And this is something that we see a lot, especially with the multi-kinase inhibitors, and especially I would say with lenvatinib and cabozantinib. And a lot of our patients on these drugs struggle a lot with loss of appetite and weight loss. Though this is just to show you how we grade these side effects. For the loss of appetite, it becomes severe if it causes weight loss. And for weight loss, the way we grade it is based on the percentage weight loss compared to a baseline weight. So if a patient loses 20% or more of their weight, then we need to stop the drug, help them regain the weight before going back on the drug, and often going down on the dose if that happens. So one of the key things I think is to monitor closely your weight and be aware if the drug you're on causes weight loss or not. And when we start a patient on a drug that can cause significant weight loss, I always tell them to monitor their weight just like they're monitoring their blood pressure and keep a diary with their weight, because sometimes we lose weight without even noticing it. And when you go back to your doctor 2-3 months later, that's only when you notice, oh, I lost 20 pounds, 30 pounds, and we're already too late at that time. So I think monitoring your weight very closely to detect early on when you're losing weight so that we can act up early, that you don't keep losing that weight and we're just catching up. The weight loss can be caused by multiple things. It can just be the drug making you lose muscle mass, but there's also many other things that the drug can cause that lead to secondary weight loss. So if you're having nausea that's not well controlled, this can lead eventually to weight loss. So make sure that's well controlled. Drugs, some of these drugs can change the way you taste food. Unfortunately, we don't have a lot to offer for that, but this can be a cause of weight loss and something you need to be mindful of. Some patients are going to say, I get full very quickly. So if that's the case, then what you should do is maybe favor smaller meal more frequently rather than trying to eat big meals and not being able to finish them. Some patients have severe dry mouth, and I'm going to give you some tips to help with that. But the dry mouth, because their mouth is so dry, they're gonna not want to eat because foods don't get down so easily. So also be mindful of that. And some patients can have mouth sores because of their chemo, and so it's too painful for them to eat. So make sure that these are well managed if you have those. And then sometimes just checking in with a dietitian can be very helpful. So they can give you tips and tricks on how to maintain your weight. Some of these tips, as I said, eating smaller meals more frequently during the day is a big one. Snacking throughout the day can also help. Favor foods that are high in proteins and calorie, because if you don't have a lot of appetite and you're just going to eat a little bit, make sure that what you're eating is giving you the most protein and calorie as possible. And then try to eat these foods first during your meal so that if you're full quickly, you got the most nutritive part of your meal rather than leaving it for the end. Favor foods that you like, things that smell good for you. Don't drink a lot while you're eating, because this can also help make you full quickly. So try to not drink while you're eating. And then milkshakes, smoothies, juices can also be good alternatives if you don't feel like eating solid foods. And then finally, protein fortified shakes like the Boost or Ensures can really be your best friend on some of these chemos to help you maintain the weight. And then if none of these things work and there's severe weight loss, we have some drugs that work as appetite stimulants, but none of these are ideal. They come with several side effects, so we try to avoid them as much as possible. The reason why I think weight loss is so important, is because it's, as I said, very, very common with the multi-kinase inhibitors. Up to 50% of patients on the clinical trials had some significant weight loss. And if you're losing significant weight, you're getting stuck in this kind of vicious circle that we really don't want to get into. You're not eating well, you're losing weight, losing muscle mass, getting weaker, more fatigued, unable to eat. And we kind of get stuck in this vicious circle that is very, very hard to get out of. And eventually you're not able to tolerate your treatment anymore or need to go down on the dose. And so we don't want to get there. So that's why it's very important to be proactive rather than reactive with the weight loss. Another side effect that can be very challenging to manage is the fatigue. And this also happens very commonly with a lot of the chemo drugs that we prescribe. And the way we grade fatigue is how much they're affecting your life. So a grade 3 fatigue is when you're not even able to take care of yourself anymore. And if that's the case, then the drug needs to be, either the dose or the drug itself needs to be revisited. Sometimes the fatigue is not due to the drug. Sometimes there's underlying conditions that are causing the fatigue. So it's important to rule these out and make sure that you have had your TSH checked recently, that you're not either hypo or hyperthyroid, because both of these things can cause fatigue. With lenvatinib, there are cases of adrenal insufficiency that have been described, and the adrenal insufficiency can cause fatigue. So if that's your case, then have your doctor check a morning cortisol level to make sure that you don't have adrenal insufficiency causing your fatigue. Anemia is also a common side effect with several of our chemos, and this can also cause fatigue. So this is another condition that you have to rule out if you're experiencing significant fatigue before blaming it on the chemo. And then several other things that come with just dealing with cancer can contribute to the fatigue. So if you're experiencing pain all the time, then obviously you're going to be more tired. So make sure that this pain is under control. And then some patients unfortunately experience depression, and this can contribute to the fatigue as well. So treating that might help. As I mentioned, if you're losing significant weight, you're going to become weaker and more fatigued. So important to focus on maintaining your weight, and then staying well hydrated is going to help with the energy level as well. And then just some more basic tips like having good sleeping habits, taking short naps throughout the day to stay energized, and staying active is very important. And I'm not talking about significant physical exercise, just some light exercise or short walks daily. This can go a long way to help you maintain your energy level. And then kind of like for the weight loss, there's meds that can help with cancer fatigue as well, but those also come with a lot of side effects, so we tend to not use them very often. We have a fatigue clinic at MD Anderson, and some patients will end up on medications for ADHD like Ritalin or Vyvanse, and this can sometimes help. But these are kind of like last resort meds. And then similar to all of the other side effects, if the fatigue is very severe, sometimes we have to hold drug or go down on the dose to help manage this. And what I always tell my patients is that you're oftentimes going to be on these drugs for a very long time. So you have to learn how to live with the disease. And if we're making you live longer, but you're living a miserable life, you're fatigued all the time, you're sleeping all day long, that's not the point, right? The point is for you to enjoy life as much as possible. And so we need to find the right balance between treating the cancer, but allowing you to have the best quality of life possible. And if this means dropping down the dose, taking the drug every other day, whatever works best for you, that's what we need to find. But the point is not for you to like tough through side effects, because this is a lifelong battle, and we can tough through things for as long. We can't do that long term. We're all human, so we need to find this right balance. The next side effect I wanted to touch upon is the hand-foot skin reaction, or hand-foot syndrome. This is another frequent side effect with the multi-kinase inhibitors. And what this entitles is patients are going to experience redness, callus formation, swelling on the hands and feet. And at more severe stages, we can even see blistering, peeling of the skin, and it can be very painful. Some patients cannot use their hands anymore or cannot walk anymore. So it's very important to know if the drug you're on causes this or not, and to be mindful if these symptoms start developing. The way to prevent this, if you're on a drug that can cause the hand-foot syndrome, is making sure that your hands and feet are well moisturized. And usually patients use lotions or cream, which are weaker moisturizers. So make sure that you're using thick stuff that are gonna really moisturize very well. Like I put some examples here. Also, if you're working a lot with your hands, try to be mindful of that and avoid as much as possible friction or activities that involve heat. both for the hands and feet, because this can worsen or precipitate the development of a hand-foot syndrome. And then if you do need to either do these activities, then make sure that you're protecting your hands and feet as much as possible. And make also sure to wear looser footwear, because again, if you're wearing very tight shoes, this can precipitate a hand-foot syndrome. And then if you do develop that, then the first line is always urea cream. This is a cream that you can get on the internet over Amazon. It helps a lot with the hand-foot syndrome in most of our patients, but there's several other things that we can use. You can use topical lidocaine for pain, or even oral drugs sometimes are needed to manage the pain. So if you do develop these symptoms, very important to talk to your doctor about them, because we have a lot of tools to help with it. And if they don't know what to do with it, then seeing a podiatrist or a dermatologist can also be of great help. And then again, just like all the other side effects, if it's grade 3 or more, if it's very severe, affecting your activities, then we hold drug and go down on the dose. Then I just wanted to give you some tips to prevent or protect your skin. So with a lot of the chemos that we use, we can see rashes and or sensitivity to the sun. So most of our patients on any of the chemos, these are some tips we're going to give them. Make sure that you're moisturizing your skin well. Avoid hot showers. Wear looser clothes so that, again, there's no friction. Use milder soaps, not soaps with a lot of added things that can be toxic for your skin. And very, very important to protect yourself from the sun and wear sunscreen, at least SPF 30. Just a word on another skin side effect that we see specifically with the BRAF inhibitors and with sorafenib. So on these drugs, we can see small skin tumors. These are examples of the skin tumors that we can see. And those are relatively common, especially if you're on a BRAF inhibitor alone. If you're on the BRAF inhibitor plus a MEK inhibitor, we see them a little bit less commonly, but they do still happen. So for all of our patients on a BRAF inhibitor, we recommend at least a yearly follow-up with a dermatologist to have your skin checked. And then usually we don't need to stop the chemo or anything. If those develop, the dermatologists are going to remove them, and usually removing them is enough. But it's important to have somebody look at your skin at least once a year if you're on a BRAF inhibitor. The next one is dry mouth, which is another very common side effect that we see with a lot of our chemo drugs, but also in patients that have gotten multiple doses of radioactive iodine. This is something that a lot of our patients have to deal with. And these are just a few tricks that can sometimes help. So make sure that you're drinking water very often during the day to keep your mouth wet, and favor water over more sugary drinks or things like that. And same thing, ice chips, sugar-free candy, sugar-free gum. It's important to keep things in your mouth that are going to stimulate the saliva, but important that they're sugar-free, not full of sugar, because this can dehydrate you more. Use a lip balm if your lips are very dry. And then there's saliva substitutes that you can buy over the counter that help most of our patients. And if these are not enough, the doctor can also prescribe some medication that are going to stimulate the saliva production. These meds are going to stimulate kind of all bodily fluids, not only the saliva. So they do come with some side effects. And so that's why we leave them as a last resort, but they can help patients in some instances where the other more supportive measures have not worked. The next side effect that I wanted to discuss was mouth sores, or what we call oral mucositis. The way we grade that and the severity depends on if it's interfering or not with your ability to eat. So grade 3 is severe pain that's not that is impeding you from eating. So the way to manage this, or help managing it at least, is to avoid foods and drinks that can irritate the mouth. So spicy foods, hot food, sour food, a lot of good stuff, but things that can irritate the mouth that are going to make the mouth sores more painful. Use a toothbrush that is soft so that you're not irritating your gums, and non-mint toothpaste. and ensure just that you're taking good care of your mouth, that you're going often to the dentist. You can use mouthwashes to just keep your mouth clean. Could be other mouthwashes that you buy at the pharmacy that are alcohol-free. Alcohol-free is very important because if they have alcohol in them, this can be irritating. Or you can make a homemade baking soda rinse with baking soda, salt, and water, which can also help just maintain a good, a clean mouth. When you do develop mouth sores, there's also several tricks that we can use. You can get over-the-counter biotin mouth rinse. If this doesn't work, which oftentimes it doesn't really work in a lot of our patients, you can get what we call the magic mouthwash. That is something that your doctor can prescribe to you that contains lidocaine, which help with the pain, and also Malox and Benadryl. And then for more painful mouth sores, you can also have lidocaine that you can either put a jelly that you put specifically on the mouth sores or a swish and spit. And finally, there's also steroids that we can use. So several things that we have up our sleeves for mouth sores as well. So important that if you have those, to recognize them and talk to your medical team, because there are things that they can recommend or prescribe to help you manage those. I think this is the last side effect I'll be discussing, and this is specific to the BRAF/MEK inhibitors, and more specifically dabrafenib trametinib, but it's a very common one, so I really wanted to touch upon it. And it's fevers with these drugs. And when we say fever, it's an oral temperature of 100.4 degrees or more. Patients can have the fevers only or with flu-like symptoms like chills, fatigue, night sweats, muscle and joint pains. And this is the most common side effect with dabrafenib trametinib, and it's also the principal cause why patients need to stop or interrupt their treatment. So it's very important to be aware that this is something that can happen with these drugs and to manage it well. The way we grade is very simple, is just based on the degree of fever and how long it's lasting. So when you're starting these drugs, know that fever can happen. And if the fever does happen, and it's the first time that it's ever happening, it's very important to make sure that nothing else is happening. You're still on chemotherapy. Yes, it's not the conventional type, but sometimes the immune system can be a little bit weakened. So it's important to make sure that you don't have an infection. And so when it's the first time that you're getting fever on these drugs, don't just assume it's a side effect from the chemo. Make sure to go see your doctor or urgent care to rule out an infection. And then you need to stop the drugs as soon as the fever happens. And of course, make your medical team aware that you're experiencing these fevers. Once we've ruled out an infection, what we're going to do is take Tylenol and Advil around the clock. And this is really important to be taking them regularly, not just when the fevers happen. You want to be proactive again, not reactive. So just take the drugs around the clock and alternate between the Advil and the Tylenol so that you're almost always taking something every 2 to 3 hours. If the fevers go away, great. And you've been fever-free for 24 hours, then you can go back on the drugs. Unfortunately, these fevers sometimes happen just once, but most commonly they're going to be recurrent, so happen again and again if we resume the drug on the same dose. And so every episode, the management is relatively similar, but if the fevers are very common, so they happen less than every 3 weeks within a month, more than 3 episodes within a month, or there's less than 3 weeks between 2 episodes of fevers, then sometimes what we do is give a small dose of prednisone to kind of prevent the fevers from coming back. So again, very important to stay in contact with your medical team continuously and letting them know if you experience these fevers, and they'll help you manage them. But know that this is a very frequent side effect with the dabrafenib trametinib. And so kind of what I've been repeating throughout my talk, but I think the key here is being well educated, knowing what side effects can come with the drug that has been prescribed to you, what tricks are there to manage the most common side effects so that you're prepared. If your drug causes nausea in 90% of cases, then maybe have your doctor prescribe anti-nausea medication up front so that you're prepared to manage these side effects if they happen. Know if the drug you're on causes high blood pressure, and if so, How often do you need to monitor your blood pressure? How are you going to communicate with your doctor to give them the blood pressure so that this is managed adequately? And then it's very important to know when you need to go to the ER, when you need to call your doctor or your medical team, and who to call if you have problems. So all of these are very important to know when you're starting a new chemotherapy, and this is key to have the best experience possible, I think, when you start a new treatment. And then obviously monitoring is key. We need to detect these side effects early on when they happen so that we're again, being proactive in managing them while they're still manageable and not wait till they become very severe and out of hand and require the drug to be stopped. Most of our patients on systemic therapy are going to have blood tests drawn every month, at least at the beginning, and sometimes even every few weeks, depending on the drug you're on. And some drugs need more than just blood tests. Some need urine analysis, EKG, heart ultrasound. So it's important to get all the appropriate testing and to have it done in a timely manner. And then, as I mentioned, for patients on dabrafenib, trametinib, we recommend seeing a dermatologist and an ophthalmologist at least once a year because of specific side effects that happen with these drugs. And we at MD Anderson kind of use this symptom list. Every time a patient that is on systemic therapy comes in to see us, our team is going to go through all of this list of side effects with them and grade the severity of side effects so that we're very well aware of what side effects they're experiencing and help them manage them. So this is very important to let your team know what you're going through and not just keep it to yourself because you're afraid of the drug being stopped or the dose being reduced. I think it's very important to be transparent so that we help you, again, have the best quality of life possible while you're living with your disease and receiving your treatment. And then my last message here is that our goal ultimately when treating thyroid cancer is to offer personalized medicine. We saw that these drugs have significant side effects. We also know that these drugs, for the most majority of cases, do not offer a cure. And once you start these treatments, you have to be on them long term. So these are not a walk in the park. And in general, thyroid cancer is slowly progressive, and most of our patients, even with advanced disease, are feeling just fine or have no symptoms at all. And so oftentimes the treatment is worse than the disease. And so the key here is knowing the right time to start therapy. And this mostly applies for the differentiated thyroid cancer, but sometimes we can wait a long time before pulling the trigger. And it's important to know this right time so that we're not putting our patients through side effects when they don't need to. So it's the conversation that you can have with your doctor. Do I really need to start treatment now, or can we wait a little bit before starting treatment? And then it's also very important that we together choose the right drug and the right dose that our patient is going to tolerate the best. And so this is what I had for you guys this afternoon, and happy to take any questions. One of the questions is, how is management of AFib, probably caused by TSH suppression for 14+ years, treated if BP is low and side effects of metoprolol are decreasing blood pressure? High-risk PDTC patient. So I think although TSH suppression is important, I think that we need to, again, find the right balance between treating the cancer and the side effects we're causing. So if you're having uncontrolled AFib because of the TSH suppression, even if your cancer is high risk, I think that we don't need to be as aggressive with TSH suppression, especially you're mentioning high risk PDTC. In poorly differentiated thyroid cancers, not sure how much aggressive TSH suppression works as opposed to differentiated thyroid cancer. So maybe just going down on the levothyroxine dose is the answer here, although it's not ideal. But if we're causing AFib because of TSH suppression, I think we need to go down on the thyroid hormone dose. Okay, another question is, what is non-aggressive TSH suppression? Well, it really depends on case by case, but it's just suppressing the TSH a little bit less. So let's say your TSH is undetectable, then maybe aiming for a TSH of 0.1, or if your TSH is 0.1, then maybe aiming a little bit higher. It's just suppressing it a little bit less is what I mean. Definitely. Okay, how about the loss of libido as a side effect to selpercatinib? Any kind of treatment help that you would recommend? So first thing, I would make sure that there's no other cause for the loss of libido. Make sure that you get your testosterone levels measured so that you don't, we're not missing out on another problem here. But if it's directly linked to sulfatinib, if it comes with erectile dysfunction, using Viagra in some patients has helped. For the low libido itself, unfortunately, there isn't great medical ways of improving that. So unfortunately, oftentimes it's something that you have to live with, but definitely have other causes of low libido looked into so that if there's anything else that we can treat, that this is addressed. Okay, the other question is, any solutions for persistent severe indigestion, kidney stones, and all of other symptoms caused by calcium calcitriol? If you're having kidney stones from your calcium calcitriol, then you're probably on too much. So I think the answer here would be to revise the dosage you're on, because if your treatment is causing kidney stones, it's probably you're on too much calcitriol and calcium.
So I'm on larotrectinib and have the muscle stiffness every day, same time. I can never like go to my full 12 hours. I take it early, every dose, wake up like I can't even move. Have you found a solution?
Honestly, I have not. It's a rare drug that we don't prescribe that often, so we're not as familiar with treating the side effect. But unfortunately, I don't know of any good way to manage the side effect. Have you tried just muscle relaxants? Does that help you? No, like there's something called Flexeril. It's like a muscle relaxant. You could maybe look into things like that. You can if it helps you. It makes you sleepy though, so maybe just for the night, do you have like muscle all the time? Yeah, that could be an idea if just the Advil Tylenol has not helped you.
Hello, thank you. I'm new to this world, so I just like for therapy, for treatment, I know like surgery and then radiation, and I'm now just learning about like different targeted therapy treatments for. So if you have been diagnosed and you're like in a monitoring phase and it seems to come back after surgery, this is the type of treatment plan that you would be on?
So it really depends. These treatments are mostly used in patients that have metastatic disease, so disease that has left the thyroid and spread to other organs. And even in these situations, as I mentioned, we don't put all of our patients that have metastatic disease on systemic therapies, because most patients with papillary or well-differentiated thyroid cancer, even if their cancer has spread outside the thyroid, it's usually very slowly progressive, and so it doesn't necessarily need to be treated. As long as it's slowly progressive, we just watch it. If it starts growing more quickly, or one of the lesions is growing and the others are stable, then we're going to look into what we call targeted therapy or localized therapy. So treating just specifically the lesion that is growing if the rest of the disease is stable. And it's only when the disease is growing in multiple places at the same time, the pace of growth is concerning, that's when we're going to want to start systemic therapy. So it's really in more advanced diseases, and not everybody who has the recurrence after the initial surgery that is going to need these treatments. The recurrence is just on the neck and there's nothing elsewhere, then oftentimes we're going to try to operate on this recurrent as a treatment.
Thank you.
I'm on a RET inhibitor right now, a new drug trial, and I do have some vision issues, kind of double vision, and it seems like it tracks with, my fatigue. As my fatigue goes up, during the day, it seems like my eyes get worse. So I don't know if there's danger to that.
You're on a new RET inhibitor, or what RET inhibitor are you on? Do you know?
The ellipsis trial.
So you're on a next generation.
Yes,
RET
next
inhibitor.
generation. Yeah.
Yeah. So again, these are drugs that we're just studying, so we
Right.
don't know as much about them. But if you're having consistently double vision, I would definitely get that checked.
Yeah. I mean, yeah.
Okay, we'd like to thank Dr. Hamidi
Thank you.
for her great presentation. Thank you very much.